Hello, viewers. Welcome to the maiden edition of our discussion on IVF-related matters. My name is Esther David. I'm an IVF administrator here at DIF Medical Center, Abuja. IVF treatment is a journey that can be painstaking, emotionally and psychologically demanding, and that's why we prioritize our patients' well-being and satisfaction. It is to this effect that this session is being organized. We know you have pressing questions as regards IVF treatment, and to give answers to your pressing questions today is our very own Dr. John O. Idahosa, consultant obstetrician and gynecologist, Chief Medical Director, Deep Medical Center, Abuja. Sir, we are so honored to have you here today on the program. Without further ado, we'd like to ask, sir, what is IVF?
IVF means in vitro fertilization.
Okay.
Actually, it should be called in vitro fertilization embryo transfer. And it means that the pregnancy, the fertilization took place outside the body. That's why it's called in vitro. Fertilization inside the human body is called in vivo fertilization.
Okay.
So that's just...
All right. Thank you very much, sir. That leads us to the second question. And it says, can IVF pregnancy be considered as natural or artificial?
The right phrase will not be natural or artificial. It should be spontaneous and assisted. The pregnancies that take place in vivo are referred to as spontaneous conception, while the ones that take place outside the body is called assisted conception. So it is spontaneous or assisted. When you say natural, then it means that one is artificial. It will suggest as if something is off about the babies conceived via in vitro fertilization, when basically they are the same.
Okay. Wow. Thank you very much, sir. We've learned today that there's nothing like artificial or natural. It's either spontaneous or assisted. And that brings us to the next question, sir. So how does this work? How does the process of IVF work, sir?
Yes. It's like asking me to describe in vitro fertilization embryo transfer. Wow.
Sir.
I'll do that. So viewers, just patiently follow me. When the girl child is still in her mother's womb, she is blessed with 2 ovaries.
Okay.
These ovaries contain a lot of follicles. The follicles contain eggs.
Okay.
By the time she gets to puberty, and she does her first menses called menarche, it will suggest that a cyclical program has started, where immature follicles that are called atretic follicles begin to mature and one becomes dominant and ovulates.
Okay.
While the girl child is still in her mother's womb, she is genetically programmed or primed as to how many follicles should be recruited from the storehouse for development every month. For some, it is 10. Others, and some people, it can be as much as 100. That explains why some women get to menopause at the age of 30. The genetic system programmed their ovaries to recruit too many eggs while they were still young.
Wow.
But average, let's say 30 follicles are recruited.
Okay.
In vivo fertilization or spontaneous pregnancy, even if 30 follicles begin to grow, only one will get to maturity. That one is called the dominant follicle. And that's the one that ovulates. But in vitro fertilization, we use medications to stimulate and help all the follicles to move from the atretic stage to the dominant stage of maturity. So maybe instead of getting one, I can get like 27, 28 follicles. Then pick the eggs, I might get some eggs. Now, under the influence of medications, I'm able to get up to 30 follicles matured. Then, at a particular stage, determined by the size of the follicle and by other hormonal assays, we know when to pick the eggs out so that it doesn't rupture in her body and we lose it. Now, it is the mechanism of preventing the premature luteinization or the premature rupture of the eggs inside the woman's body that defines what you hear in IVF as protocols. You have the antagonist protocol, you have the agonist protocol, you have the long, the short, the extra long. Those are all terminologies we use to define the processes we use to make sure that eggs don't rupture inside a woman's body. So at a particular time determined by the use of drugs, the size of the follicles, the woman is taken to the theater for what we call oocyte recovery or egg collection. So under anesthesia, brief process, 15 minutes, transvaginal scan guidance, and an aspiration needle.
Okay.
We will puncture through the vagina, assess the ovaries, a scan will guide us to where the follicles are. We put the follicles, pick the eggs out, give it to the embryologist, who will then allow the eggs to rest for about 4 hours after retrieval, and then they're now fertilized with the husband's sperm, either by what we call intracytoplasmic sperm injection, in which we take one sperm and fertilize one egg, or we allow some sperms to just relate with an egg, and then the best sperm should be able to enter itself. Whether it is by that process or it is through an ICSI program, which we call the intracytoplasmic sperm injection, is still in vitro fertilization. So the in vitro fertilization takes place, and then wait for the harvested eggs to grow until it gets to a stage, maybe day 5, when it's called a blastocyst, and we transfer it back into the woman's womb. So in vitro fertilization, embryo transfer has taken place.
Wow. Thank you so much for that exposition, sir. Recently, we've observed that we've seen advanced women in age getting pregnant and having babies on their own. On that note, we'd like to ask, sir, who is fit for an IVF treatment?
When the IVF program started, now 47 years ago, by the pioneering effort of Robert Edwards and Stepton, it was designed to deal with infertility due to tubal blockage. Now, naturally, pregnancy is designed to take place in the fallopian tube, in the ampullary portion, in the outward portion of the fallopian tube. Maybe in the next episode, I will come with things to tell you more about where fallopian tube is, how it relates to the ovaries, how the needles look like, and so on. So maybe that will make up the next episode. I'm sure. So viewers, just wait for that. So it was meant to deal with infertility or subfertility due to tubal blockage. But as time went on, we realized that it could also address infertility due to other factors. Other factors like the uterus is not healthy enough due to previous surgery, previous miscarriage, previous termination of pregnancies, or she has a hostile endometrium. There has a hostile cervical mucus plug. So that there's an antigen-antibody reaction in which the woman's cervix does not allow sperm to penetrate, to pass through it, let alone get to the ampullary portion of the fallopian tube. So it was not advanced for that reason. It was then advanced to treat women who are aged, maybe 50, 60, they don't longer ovulate, yet we may be able to pick eggs from a younger woman through an egg donation program and do this. So Now it extended to treat male infertility. Men who have poor sperm, low sperm count, poor sperm motility, bad morphology, or that is how the sperms look like. Then, you see, it extended into the male domain. So it's still medical. It extended into men who have varicocele because the testis is subjected to a lot of warmth, so the sperm quality is poor. Okay, it was now extended, used to treat men with various types of erectile dysfunction who might not be able to just produce sperm. So it's still medical. Now later advanced into the social realm.
Okay.
To address pregnant women who want to be pregnant for multiple pregnancies, particularly in a society where multiple pregnancies is celebrated. You use it to address women who want to have a gender selection. You have a family has 4 boys, they need a girl. Oh, you have 3 girls, you need a boy. You can also use IVF to address such a challenge. Now come women or families that have some forms of congenital abnormalities. The only means by which you can eliminate that congenital abnormality from that family is to do in vitro fertilization before the embryo transfer. On day 5 of the embryo growth, you do what we call a biopsy and then do a pre-genetic screening. We'll determine which embryo is normal and abnormal. You see, we're expanding its social use. Now we live in a society where women are AS and they marry AS. So how are you going to eliminate the SS gene? It's in vitro fertilization. Now women are pursuing their career with a lot of vigor. And so you see women getting married late. So they can now pick their eggs while they are young, store it, and then when they now need it, we can unfreeze it and use it for assisted conception. All right? So it's a social thing. There are also women who want to conceive at a particular time of their lives. Either they're running for office or they're in an office. They don't want to be pregnant while in the office. So they generate eggs, fertilize with the spouse's sperm, store the embryo, and then transfer it later. Or women who want to have babies deliver when they're in office. Oh, a state house. Oh, you're the governor of a state or the governor's wife. Yes, you can have a state house baby. There are people who want to have deliveries on a particular date. Or they want to share birth date with the kids. Then we can use the in vitro fertilization to manipulate and get deliveries occurring at a particular time. You see, it's social.
Yeah.
And then you have the men who, for one reason or the other, want to define how they want to spread babies here and there. In vitro fertilization can also be used to. So you see, we're now extending to the social domain, and it begins to appear as if the social reasons are even getting more than medical reasons for assisted conception.
All right. Thank you so much, sir. So, sir, with the availability of knowledge right now, would you say that IVF treatment is 100% guaranteed? And if no, why does it fail sometimes?
In the laboratory, when you fertilize the egg, the success rate is 100%. But when you take the embryos and transfer into the woman, factors beyond us begin to cause what we call implantation failure.
Okay.
The embryos will fail to implant either because the embryo is intrinsically abnormal. Morphologically, that is externally, it looks good and great. But when you put it inside a woman, it expresses its inherent genetic challenge that will prevent implantation. So that's why. Then you have the environment in which you're going to drop the embryos. You're going to drop the embryos in the womb. That womb has to be good, must be fed, must be well prepared. So if she has a scar from a previous myomectomy, a previous cesarean section, a scarring that occurred because of miscarriage carried out occurred due to a termination of pregnancy, the embryo will not be able to implant on that side. Oh, if she has fluid in the endometrium, unfortunately, she cannot. Then, if she has an infected endometrium, and that is say that in Nigeria, the commonest reason for implantation failure is infection of the endometrium. So once the endometrium is infected, it produces hostile environment and agents that will just destroy the embryos. So so these are the reasons. But at the DIF Medical Center, success rate, basic success rate is 63.6%. What that means, if we take 10 patients through IVF, 6 to 7 will get pregnant at the first attempt. And that is good. And the reason why the success rate is that high is because of the pedantic preparation we do, the pedantic preparation of the woman's womb for pregnancy, to the fact that the embryo is transferred under ultrasound scan guidance. The third reason is that we make sure that the embryos get to the blastocyst stage. Number 4, we do a mock embryo transfer. Any center that does a mock embryo transfer will notice that it will contribute an increase and a 5% increase of their success rate. No matter how challenging it is, it's good for people to do the mock embryo transfer, which we do at the DIF Medical Center. The 5th reason why we think there is that high success rate is that we drop more embryos, like maybe 3 embryos, 4 embryos. The cumulative effect of that number of embryos does result in a higher success rate. The 6th reason is we culture the embryos to get to the blastocyst stage before we drop them. These are the 6 reasons why we think there's an increase in there's such a high success rate at the DIF Medical Center here in Abuja.
All right. Thank you so much, sir. In the course of this discussion, you've made us understand that in vitro fertilization, medications are used to mature more eggs. And I want to ask, these medications, do they have any adverse effects on the body? Are there side effects to these medications, sir?
Well, 47 years have gone by since the breakthrough, the birth of Louis Joy Brown. And the fears people had all the while has been that there will be an increase in carcinoma of the ovary, carcinoma of the endometrium, and carcinoma of the breast. But we realized that no, these carcinomas have not increased, particularly the carcinoma of the ovary. So, which means it does not increase, it doesn't cause cancer. The other fears people had was the effect of these medications on the kidneys that is necessary to metabolize them. But luckily, the new medications that are recombinant, which means they are synthesized, not from urine, has changed the narrative. So no increase in kidney disease or liver disease. So basically it is safe. Okay. But the only thing the woman may notice is a slight increase in her weight by about 1 or 2 kilograms. It's just increasing, and the weight gain is just because of increase in accumulation of fluid, which will definitely disappear when the drugs are over, when the stimulation is over. However, there is one complication that we must note. It's called the ovarian hyperstimulation syndrome, in which the woman has an exaggerated response to the medications. And it will now manifest with some bloating and some challenges in fluid accumulation, challenges with the maybe breathing and so on and so forth. But it's something we won't do in this episode. Definitely we need an episode to discuss the ovarian hyperstimulation syndrome, how it works, and what the hospital does to mitigate it, against it. Okay? I think those are the complications you can ever see.
All right. And that actually brings us to the end of this edition today. We want to thank you so much, sir, for making our time out of your very busy schedule to answer these questions today. And I hope, viewers, you've learned one or two from this edition. We hope you would oblige us the opportunity again at subsequent editions, sir. Until we come your way again, remember, in this time and age, no woman is barren. Thank you so much. Bye for now.